Hello, everyone. Welcome to another session of Zooming Through ID. I'm Dr. Gopal, an infectious disease specialist trained at Duke University, been practicing in South Florida area for over 20 years. I am the APD here for Infectious Disease Fellowship program, and I'm also internal medicine faculty. I am the medical director for infectious disease infection control, and I also chair the antibiotic stewardship. Teaching is one of my passion. Internal medicine residents rotate with me, and they pick a topic of interest, or we assign them a topic, um, and they do research. They study about it, and this is like a focused teaching session where the residents and fellows take ownership of what they learned and they teach what they have learned us. And today we have a very interesting topic, and Alfonso is going to talk about that topic, and it's strongyloids. Alfonso was doing infectious disease rotation with me, and she was very good. And she wants to be a hospitalist, and she has great bedside manners, and she saw a lot of infectious disease patients, and I hope she learned a lot. And let me introduce you to Alfonso, and she's going to talk about her topic.
Yeah. Hi, I'm Alfonso. I'm one of the third year IM resident, and I work with I got a chance to work with Dr. Gopal for the last 2 weeks in infectious disease, and yeah, my future plans are to become a hospitalist. So yeah, so I can get started on the slides and
So the
just
topic today is strongyloids. Yeah.
um, yeah. So I will be talking about like she mentioned, the topic strongyloiditis.
Yeah, I can see the slide.
Oh, perfect. Okay. So just to go over the overview, introduction, the pathogen is Strongyloides stercoralis. It's soil transmitted helminth. So it's the only helminth capable of replicating entirely inside the human host. So it allows for lifelong subclinical infection. So going over the epidemiology and prevalence, it affects about 300 to 600 million people globally. It's underdiagnosed in both endemic and non-endemic areas. Example, the US immigrants, travelers, veterans. The parasite is prevalent in the southeastern United States and Southeast Asia. And why this topic is important is the critical clinical relevance, the corticosteroid trap. So it can be asymptomatic or mild infection can persist silently for decades. But the danger happens is if you're initiating an immunosuppressive therapy, specifically like corticosteroids, even if it's short courses. It inhibits the host immune response and it accelerates the auto-infection cycle into overdrive. Um, and then severe morbidity and mortality, the hyperinfection syndrome and dissemination. So the larvae can migrate in massive numbers to organs outside the GI and pulmonary tract. For example, the CNS, liver, the skin. So complications can include like it's often accompanied by polymicrobial enteric bacteremia or meningitis as the larva carries gut flora with them. So the states, while uncomplicated, strongyloides is highly treatable. Person is ivermectin. Disseminated diseases can carries a staggering mortality rate of 70 to 90%. So going over the etiology, so the pathogen is the Strongyloides stercoralis, the threadworm, the nematode. The transmission is primarily it's a percutaneous penetration primarily via feet, like if you have any type of cuts or something. And the habitat and transmission, it's in a warm, moist climates in the tropics. Risk factor include walking barefoot. Just a little small picture of the life cycle in hyperinfection. So the eggs can hatch in the intestine, the larvae gets excreted by stool, and in the soil there's percutaneous skin penetration by feet, and then it gets taken up via bronchial system, the pharynx, can migrate to the pharynx and you cough it up, and it gets swallowed, which can cause auto-infection, and the adults gets there and the eggs get deposited. So for when I'm saying hyperinfection, it means some larvae penetrate the intestinal wall, enter the bloodstream, which is rare. So this is a picture of the life cycle. So just the free living, it's a better picture of explaining everything. The free living cycle. So the rhabetiform larvae gets in the intestine or excreted in the stool. I'm at the number one if you guys want to follow along. And then it gets the development into free living adult worms. And eggs are produced by fertilized female worms. And then rhabetiform larvae hatch from embryonated eggs. The rhabetiform larvae develops into filariform larvae, which is like the infective um, larvae. It penetrates the intact skin of the definitive host. This is the free living cycles. Now we get into the parasitic cycle. So the filariform larvae migrates by various pathways into the small intestine where they become adults. And the parasitic adult female um, in the small intestine, the egg is deposited in the intestinal mucosa. The rhabetiform larvae hatch and migrate into intestinal lumen. And then the autoinfection, the rhabetiform larvae in the large intestine become filariform, penetrates the intestinal mucosa or perianal skin, and it can migrate to any other organ. And then dogs can also serve as a definitive host. So clinical features, patients are usually asymptomatic or have mild symptoms during the acute and chronic infection. In the acute infection, the cutaneous phase, there's swelling, erythema, maculopapular rash at the site of larval penetration. So larva occurrence is a raised serpentinous lesion or urticarial tracts due to migration of larvae under the skin in autoinfection. And this is actually a pathognomonic for the Strongyloides stercoralis infection. If you look at the bottom, there's a picture of the larva occurrence. And there's a pulmonary phase. You can have dry cough, wheezing, hemoptysis, rarely pneumonia, known as the Loeffler syndrome. And the intestinal phase can have inflammation, duodenitis, abdominal pain, diarrhea, anorexia, nausea, vomiting. So the incubation period ranges from 1 to 4 weeks. Acute local, the cutaneous reaction to the larval penetration is immediate. Pulmonary symptoms develop like within about a week, and intestinal symptoms about 3 to 4 weeks after the initial infection. And then chronic infection, you can have diarrhea, occasional vomiting, constipation, and the larva occurrence. Again, that's like the picture of the larva occurrence. And these are some great pictures of like the clinical features. Like the first panel A, you can see the larva occurrence occurring, and then same in B, it's like in a patient with hyperinfection. And then C is just showing duodenal stricture. There's larvae of this in the gut mucosa, and then well, it's the pictures are in the D and E panel. And then in panel F, you have the larvae from the bronchial alveolar lavage. And then in G, it's with the calculofluoral staining. And then H, you have a plain radiograph of the chest showing diffuse ground glass opacity and consolidation in the lung. And then in I, it's showing a superficial ulceration, oozing erythema of the mucus and of the descending colon. And in J, it's showing erythema and scattered erosion. So these are just like some pictures of people with strongyloides. So for diagnosis, you can do a stool microscopy. So serial stool examination with mobile, you may be able to see the mobile rhabetiform larvae, which is in the picture on the right side. Its characteristics include like rounded tail tip, the short buccal cavity, the circle overlay, its genital primordium. Oh, sorry, this right here in this, and then it's which is visible approximately in the middle of the worm. And then you can do, when you do the CBC, it may show eosinophilia because it's like the worm. And then, but the eosinophilia is often absent in disseminated strongyloidesis and hyperinfection. And the diagnosis can be confirmed by larval detection in stool, but stool studies can often be negative. That's when you do serology, ELISA for IgG, which can be positive even in patients with negative stool studies. So suspected patients with two negative stool samples and serology testing may require duodenal aspiration and the string test and Tero test. As first for treatment, the preferred treatment is ivermectin. So the drug is ivermectin, typically comes in 3 mg tablets. The dose is about 200 microgram per kilogram orally. So schedule, most commonly you give the single dose of 200 microgram per kilogram Alternatively, many clinicians use 200 microgram per kilogram once daily for 2 days, and you take it on an empty stomach with water. So for immunocompromised patients or patients with hyperinfection or disseminated disease, multiple or prolonged courses and a closer ID consultation are usually needed. There's really no optimal regimen that's like firmly established, and cure may not be achievable in some cases. So after treatment of the intestinal strongyloidesis, a follow-up stool examination is required to confirm the eradication of the Strongyloides stercoralis. If the larvae does reappear, then retreatment is indicated. In practice, many clinicians repeat the stool O1 parasite under the Strongyloides serology, which several weeks to months after therapy. In immunocompromised patients, perform serial testing and often give repeated courses, for example, like at 2-week intervals if there is ongoing infection. And then as far as alternative treatment, you can use like benzimidazole, like albendazole. It's an alternative off-label agent for strongyloidesis. Ivermectin is preferred, but when albendazole is used, this is the dosing and course for uncomplicated strongyloidesis. Drug is obviously albendazole, 400 milligram twice daily by mouth. Do it for 7 days. Take it with meal to enhance absorption. And again, it's indicated for uncomplicated acute or chronic strongyloidesis when ivermectin cannot be used or is unavailable. Again, like for severe hyperinfection, disseminated disease, ivermectin is recommended instead, often for a prolonged course until stool or sputum are negative for 2 weeks. Albendazole is not first line in that setting. Just check baseline LFTs to avoid significant hepatic impairment or pregnancy if possible. Then complication, like I mentioned before, the hyperinfection syndrome, there's increased rate of autoinfection due to immunosuppression, like steroid therapy, HTLV-1 co-infection, transplant. They can cause GI symptoms, which include abdominal pain, ileus, mucosal ulcers. You can have pulmonary symptoms like pneumonitis, respiratory failure. Dermatologic signs include recurrent rash, the larva occurrence. Then complications of dissemination itself, the organ dysfunction, septic shock, meningitis. Strongyloidesis completes its entire life cycle within its host. In the intestinal tract, the egg hatch into larvae that reinfect the host and may result in a high parasitic burden within a short period of time. For prevention, the primary prevention is wear shoes if walking on soil, avoid contact with sewage and fecal matter. So now I have some questions that we can go over. So the first one, patient is a 38-year-old male who immigrated from Laos 5 years ago, presents with intermittent epigastric pain for several months. It's worse with food, unresponsive to H2 blockers. He was recently diagnosed with asthma 2 years ago. He was hospitalized 2 months ago for pneumonia and asthma exacerbation. He was treated with systemic corticosteroids. The physical exam was unremarkable, afebrile. Labs should look, although the pertinent labs were not the test. Labs showed leukocytes of 8,200, and the eosinophils were 15% of that. So a significant peripheral eosinophilia. CBC and BMP otherwise were normal. Diagnostic-wise, chest CT was done, which was normal. Two separate stool samples for ova and parasites are negative. So what is the next best step management for this patient? So the answer choices include bone marrow biopsy, B, celiac disease antibodies, C, serology for Helicobacter pylori, D, serology for parasitic infection, E, skin testing for Aspergillus. So for this patient, the next best step is to serology for the parasitic infection. So just going over the diagnostic pitfall. The stool microscopy, the oviparasite has notoriously low sensitivity for strongyloidesis and is frequently negative. So if you have the suspicion is high, especially he's from like a place where it's high getting the strongyloidesis, the next step would be to do a serology, IgG ELISA, which has high sensitivity. The patient's presentation perfectly matches chronic strongyloidesis, the epigastric pain, the asthma-like pulmonary symptoms, and peripheral eosinophilia. And he had the steroid warning. So he recently took the steroids, and it accelerates the strongyloidesis life cycle. risking a transition from chronic infection to fatal hyperinfection syndrome. So just going over the other answers, the bone marrow biopsy, it's invasive and appropriate as an initial step for mild to moderate eosinophilia before completing a thorough travel and parasitic workup. And B, celiac disease antibodies, it can cause GI distress, but you do not typically present with eosinophilia or respiratory flares, and typically features iron deficiency anemia. Then in terms of serology for Helicobacter pylori, testing is indicated in patients with dyspepsia, gastric mold lymphoma, or history of active peptic ulcer disease. And for E, the skin testing for aspergillus, GI symptoms are unlikely in patients with allergic bronchopulmonary aspergillosis, plus the CT scan usually shows fleeting infiltrates or it can show bronchiectasis. Right, next question is a 22-year-old man comes to the physician because of abdominal pain, diarrhea, weight loss that started after a recent backpacking trip in Southeast Asia, does not smoke or drink alcohol. His leukocyte count is 7,500. 61% of it's segmented neutrophils, 13% eosinophils, and 26% lymphocytes. Stool microscopy shows the rhabdoform larvae. The patient is most likely to develop which of the following? A. Hematuria. B. Perianal serpentinous rash. C. Rectal prolapse. D. Peripheral lymphedema. So this question, the answer is the peripheral serpentinous rash. The rhabdoform larvae on stool microscopy, the eosinophilia, and recent travel history to Southeast Asia are consistent with Strongyloides stercoralis infection. So regarding the other choices, the hematuria, typically, you see that in the schistosoma species, which can cause the hematuria, reproduce in the portal venous system, targeting the bladder veins or after skin penetration. It's endemic to Africa, South America, and China, not Southeast Asia. And hematuria is not a feature of strongyloidesis. Rectal prolapse, it's typically seen in children with trichuriasis, a whipworm, the trichuriasis trichiuria, the infection that is transmitted through ingestion of undercooked meat. Rectal prolapse is not a common feature of strongyloidesis. And peripheral lymphedema, again, is elephantitis is characterized by lymphedema and is caused by Wucheria bancrofti, the roundworm. Lymphatic infiltration and obstruction by the worms leads to painful edema, lymphadenopathy, and fever. One more question. This one, a 38-year-old man comes to the physician because of a 2-week history of abdominal pain and itchy rash on his buttock. He also has fever, nausea, and diarrhea with mucoid stools. 1 week ago, the patient returned from Indonesia, where he went for vacation. Physical exam showed erythematous serpiginous lesions located in the perianal region and the posterior thighs. His leukocyte count is 9,000 with 25% eosinophils. Further eval is most likely to show which of the following findings: A. Rhabdoform larvae on stool microscopy, B. Axon tape test, C. oocytes on acid-fast stool stain, D. Giardia lamblia antibodies on stool immunoassay. So for this, the answer is A, the rhabdoform larvae on stool microscopy. This patient's fever, the GI symptoms, the abdominal pain, the nausea, the diarrhea, plus the serpentinous rash, plus the eosinophilia, and the recent travel to a tropical area is highly suggestive of strongyloidesis. Why the other tests, the answer choices were wrong. The axon tape test, the detection of axon tape test is diagnostic of enterobiasis, which causes nausea, abdominal pain, and pruritus. However, pruritus and enterobiasis is typically limited to the perianal region and is not associated with an erythematous serpiginous rash extending onto the buttock and thighs. Furthermore, this condition is most commonly seen in pediatric patients. Then C, the oocytes on acid-fast stool stain. Detection of oocyst on acid-fast stain is diagnostic of cryptosporidiosis. Abdominal pain, nausea, persistent diarrhea are features of it, and outbreaks can occur worldwide, including Indonesia, especially among travelers. However, cryptosporidiosis would not explain this patient's eosinophilia and erythematous serpiginous rash on his thighs and buttock. Then regarding Giardia antibodies on stool immunoassay, detection of Giardia lamblia antibodies on the stool is diagnostic of giardiasis. Abdominal pain, diarrhea are features of it, and infection is more likely after travel to tropical region. However, it would not explain this patient's eosinophilia or erythematous serpentinous rash on his thighs and buttock. So in summary, you should have like a high index of suspicion, like consider strongyloiditis in patients from endemic areas, like from southeastern US, Southeast Asia, when they're presenting with abdominal pain, respiratory symptoms, and peripheral eosinophilia. And the autoinfection danger, so Strongyloides stercoralis, can complete its entire life cycle within its host. Immunosuppression, especially steroids, can trigger a hyperinfection syndrome, causing multi-organ dissemination and shock. The bacteremia clue. So larvae migrating from the GI tract can carry intestinal flora into the bloodstream. So unexplained gram-negative bacteremia like E. coli in a patient from an endemic area demands a strongyloides testing. And then regarding diagnostic escalation, so initially you start out with the stool microscopy, which often can be false negative, and plus the serology, IgG, ELISA. And if you have refractory high suspicions, then do duodenal aspiration or string test. And then for first-line treatment, ivermectin is the preferred agent, and then albendazole is the alternative. And for references, there's actually a paper from Nature Reviews. I took most of the information from this article. I put the information of the citation. It has like the link to it too. If you guys want to reach out and look into it. And then the rest are references. And that's all I have. Thank you.
Great. It was great presentation. Couple of points to add on. Ivermectin, that is the drug of choice, and the mechanism of action is it activates the nematode glutamate gated chloride channel, and it causes muscle paralysis, and that is the mechanism. And the side effects of ivermectin is seizure. It can cause ataxia, confusion, but that's only in high doses. Usually, the lower doses, it doesn't cause that much issues. Um, so the So yeah, it was great presentation, Alfonso. And one, I want to share a very interesting case that I saw. Seen a few cases. There was a patient who was very sick, got admitted to ICU got intubated, then had E. coli bacteremia. There was no clear source. The urine was okay. The CAT scan of the abdomen didn't show any source. Patient was being treated with broad spectrum antibiotic, and then bronchoscopy was done, and then the bronch revealed the larvae. And that's when the strongyloides diagnosis came into effect. And the patient did have strongyloides, hyperinfection, and then the E. coli bacteremia was there. As you had mentioned in your presentation, the patient did not have any eosinophilia in the CBC. The story was, I mean, he got intubated, he got better. We treated with ivermectin also, and then treated the E. coli bacteremia. The story was there was no travel history. This is a patient who had COPD. He had multiple exacerbation, had multiple courses of steroid. So after he got extubated, we got the history that he was living in Mississippi area, in the farm area, and he was walking barefooted during the growing up years. And he had multiple COPD exacerbation, got steroids, and that caused the strongyloids to be triggered. So the key is for strongyloids, the risk factors, as I mentioned, steroids is a big one, and there is an association with HTLV1. So this case, actually, I presented it to the ACP during my training, and it was one of the finalists. And we made it like a quiz, and the key history, we got it only after, because after the patient got extubated, he didn't have any family members. So it was a cool case. Okay, so thank you everyone for joining.